Please, Dr. Williams.
Thank you for everyone. And those were 3 brilliant talks, really exciting work that you show there. So congratulations. It was more really a comment, I guess, for Andrea and possibly also to highlight to Tim as well. I mean, you were showing a lot of techniques to advance mapping. And a lot of this depends upon either signal processing or using the map outside of the lab. And I quite liked your pitch to the companies to integrate these mapping techniques or to allow us to more automatically measure data, helping perhaps your work as well, Luigi. I just pick up on one example. So you mentioned electrogram duration, and relating that back to OpenEP, we actually were interested in electrogram duration. I was checking just now. We added the function back in 2012. And then actually in 2020, we added a helper function, which makes it really easy to measure electrogram duration and then create maps. Now, if you then have your data stored within the OpenEP format, you now have access to all of the remaining tools within the interface. So actually, Tim, as well, it's to highlight that the pitch really is that if we can get the data into our standard format, all of those tools then become available to you. And Luigi, you don't need to reannotate 200 electrograms just to get an electrogram duration map.
Thank you.
So yeah, this is what we were talking about, right? That if we find that little common thing, the common language we can speak with each other, that's always wonderful things come out. Now the EGM duration is not so simple. So I mean, it's measuring repolarization is not so simple, even if we have the whole signal and the whole duration, because sometimes the T wave is flat. Sometimes it's T wave negative, positive. We don't even know where to annotate. So it's not only we have talked a lot about this. There are 2 ways to measure the end of the repolarization. We have the Wyatt and the alternative method. There was very long time a discussion which one we should use. Should we use always the positive dV/dt? Should we use with negative and positive T wave something else? And a lot of people say different things. So but if we have the data, I mean, I completely agree with you. Let's look at it together. We have, I don't know how many maps available. I also have that. I mean, we all have that very detailed map. So let's look at it together.
Serge.
Yeah, thank you. Amazing session. It was really exciting. The 3 talks were really great. I have 2 very short questions. The first one is for Andrea, obviously. First, the talk was very brilliant. I did well to drive your car from the airport. I did well.
I can tell you, you really did well.
Yeah. Yeah, she told me.
Yes. When she's a driver, it's quite of a roller coaster, actually.
So this is my question for you. I really like the end of your presentation about the genes. And by the way, it was excellent because then the talk about the Brugada makes a lot of sense. It seems very logical to go in this direction. And I really believe that this is very important for the future. But in the practical way, what is your attitude today when you have a difficult AFib ablation to ablate, a persistent more than 1 year or even more? What is your choice? Which kind of strategy? I would like to understand a little bit what you decide to perform in this kind of situation.
We might ask all the 3 to answer this.
Why not?
Individually.
Why not? Why not?
I think, I mean, it depends really on the population that you're treating. I mean, what I notice, I travel a lot in my career. I work in different environments, and you need to understand. I think you need to do a little bit of epidemiology. And if you see, this is what I think. You need to be pragmatic and understanding, what you can give to your patients. My approach is an approach that goes, a little bit towards a little bit of a pragmatic approach, because I have a population that approaches 7-year-olds as average, and actually I have to maximize the time in the lab, and so I think 3D mapping can help, understanding what is going on in persistent AF patients. But you have also a timeline to expect. And I would say that probably not here in Belgium, but in France, in Italy, we have a long waiting list, for atrial fibrillation ablation. And my question that also to you, Serge, is that how much, we can push our procedure in terms of timing. How much is ethical to, let a procedure last? So my feeling is that we need to be practical, and I think age could be a way to discern, what could be the approach. But I'm changing the approach after PFA, and I'm going towards a more anatomical approach. That is completely, a personal approach. I mean, in that way, and I'm not trying to convince any.
Okay, PFA veins only, or
no, clearly. I mean, that's something that you convinced me today to continue to do that. To be honest, I'm not a fan of doing only PVI. Yeah, and
okay, thank you.
Luigi.
So my approach in long-standing persistent AFib is vein, so PFA of course, PVI wide, and then posterior wall, CTI, and cardioversion. Personally, I don't like to go to termination of AFib, and actually there is not yet data. Maybe in the next future we will have, but not yet the data literature to go outside the PVI plus posterior wall. So I will stay for that, PVI posterior wall, and CTI and cardioversion, and then clinical evolution.
CTI, all patients. CTI,
Yeah.
okay. With RF?
RF, yes.
Okay.
And clinical evolution. Okay. If they come back, maybe as you showed, the mitral line, if they come back with a flutter, but personally, I would prefer to go with catheters like Affera, because you have a higher chance to block the mitral line compared to other technology.
Thank you.
You want to hear what I do?
The best for the last, huh?
So I think I think it became difficult because when we had the point-by-point time, if I made the map baseline and if I saw extensive scarring in those patients, really with a very high, more than 15% burden of low voltage zones, then I would look at the location and I would try to treat the location. We stopped, I think, Jean-Baptiste, we did together the stepwise approach. You remember in 2011, 12, 13? I mean, it's not that I have never done anything as an PVI, but I stopped doing it because we had the recurrence rate of atrial tachycardia was so extremely high, and because the single procedural success rate is 20% if you do focal ablations. On 5 years, as we have seen. So what I did when I saw a patient with mostly 70% of the scar in our low voltage mapping zones are anterior. So I did frequently, they already have slowed conduction. So I would do in an older patient. These are usually ladies, frequently non-dilated left atrium. So I added frequently an anterior mitral line to this patient. Now, for me, the problems, there is one extra piece of evidence which we didn't have the time to talk about. But so the other reason why I'm with long-standing persistent atrial fibrillation, you need to be careful because we did a remapping study in 20 patients who came back and we compared the low voltage zones, both of them in sinus treatment, because in those patients it's important to map in sinus. And what we found that some of these regions, so patients with lower burden regress. So there is a transient structural remodeling. So maybe a region that during the long-standing persistent you see as scar today, within 1 year at the redo procedure, if they have paroxysmal AF, only recurrence, it's going to be less. So that's the other reason why I would wait to treat during first procedure extensively. Mm-hmm. But for me, the real problem are the patients which I have no idea what to do with, and that's why I'm looking at to the representation data. The real problem are the patients who do not have scar, and they have recurrent AFib with isolated veins. I think those patients, I don't know what to do, especially if they are young, because on those I would never do an anteromitral line because you kill the conduction. Those patients, I don't know what to do. But now with the Farapulse time, it's difficult because I don't have that map. So I have no idea if there is underlying abnormal potential, abnormal substrate, structural substrate, or is there is anything electrical happening. I would probably look at the rapidity of the pulmonary vein firing to decide if I go more than posterior wall or not.
And if you have the map with PFA, with the Affera, for example?
That's a good question. That I don't know yet. That's a very good question, actually. Probably we should do a randomized study about that to see if they have extensive anterior scar. But this is exactly what we are missing, this kind of data, and also a tool which is going to completely block lines. Now, I do believe I like lines. Why do I like lines? Because I think more and more data is emerging that actually, if there is substrate, there is localized re-entry from circuits from 2 to 3 centimeters, which is maybe even more of this is in my opinion, is sustaining AF. Macro reentries, so the roof-dependent perimetral, we rarely see, and there is also new data coming out for computer modeling that it's macro reentries were, in my opinion, iatrogenic from the stepwise approach. I stop here.
Okay, very interesting. I will come back next year to ask the same question.
But that's the whole point of it.
Yeah. No, exactly.
So I think. So I had some questions. You answered mine. So I was asking you if in a paroxysmal AF patient, he's in sinus rhythm. This idea of having veins firing very much or much faster is interesting. Would you induce him, Andrea?
So that's the induce AF study. So Marco published this study, the induce AF, and we couldn't. It's incredible that 3 years ago I couldn't get it anywhere. I have to shut up. No, I can. So we did this, and we still, if we were able to induce AF and the veins were fast, those patients had very good outcome with PVI only approach. Yeah.
And if he had an anterior scar, also you just left it because it's going to disappear.
The thing is that so for one or other reasons, the patients who have anterior scar have it's extremely good correlation. They have very slow veins.
That's interesting. Thank you. So we will induce. I tend to agree with my friend Antonio on PVI plus, even if I believe that PVI should be done. But there's an amount of population that we need to do more. Luigi. So it seems that AT is more frequent after ablation of Brugada syndrome. Why?
Yeah, very good question. Actually, I think that is because of the substrate that these patients have a slow conduction, and we know that these macro-reentrant atrial tachycardias are related to slow conduction. So I think this is the reason, most probably. Yeah.
So would you advise to give isoprel after, or just to try to induce these atrial tachys after PVI to see the responders or non-responders?
Yeah, good question. Actually, isoprel is an antidote to Brugada syndrome, so it should increase the conduction velocity. So paradoxically, it should decrease the probability to induce an atrial tachycardia. No, I know. I mean, there is. Yeah, no, it's a good question. We don't know. I mean, yeah. Actually, nobody knows. We never tried. We can study. The problem is that it's only 60 patients. We are the largest center in the world. So, we can try to induce. Yes.
I am very curious if to look at the SCN5A data, and also to link it to atria. I mean, to the stroke. Do you think they have more scar Brugada patients if we would look at their voltage map? That do they have more scar? You think, and is it dependent on SCN5A class 4 or 5 or not?
Yeah, actually, we didn't see like a scar in terms of voltage in our study. So it's more like a functional slow conduction. And probably the appendage is so delayed and it's so slow that they can have thrombus and they can have a stroke. Yeah, because also at this ECGI map, you can see that is incredible. The left atrium is so delayed, so that's probably the mechanism. Yeah.
I want to ask one question. Last question, if nobody. One question to Antonio. Yeah, two, please. So. Two questions. It's very sobering, the fact that PFA doesn't work on the ganglionated autonomic system. Okay,
This is the question I wanted to ask.
Okay, so I have this absurd idea of why does PFA give the same results as thermal? Is it because thermal is gapping because of touching ganglionated plexi, but is reconnecting more? And PFA is reconnecting less? Would this be an explanation? And if so, would we have the best case scenario in having what already catheter we have would be the Affera catheter, which would permit us to do persistent PVI, and then with PFA, and then aggress the ganglionated plexi with radiofrequency? I want to hear your comment.
I mean, you answer yourself. I mean, it's very clear the answer. I think one answer could be that PFA, as showed in the work of Domenico, was assuring a better PVI durability, and so that's for sure. It's the mainstay of treatment of atrial fibrillation. So if you obtain a longer PVI isolation, you're gonna get a longer time in sinus rhythm. Regardless of the concomitant treatment of ganglionated plexi. I think also, the study are done mainly with this large fingerprint catheter, and so I guess our ablation cannot be really compared with what we were doing with the radiofrequency ablation. And so the feeling is that with PFA, you are actually getting a higher amount of ablation in the left atrium, and this could be also an answer why, the results are so convincing. I think even if you have like a ganglion plexi that is working, but the cardiac tissue is not working, so it's like you kill again the ganglion plexi. And that's my feeling. And speaking about Affera, of course, having catheters that can actually give you the choice, to toggling between PFA and the radiofrequency would be a plus. If you want to address ganglion plexi in your in the treatment of your patients.
My question was, so because we have the same results, but we have more recovery in thermal. So would it be because these same results, because thermal is catching up because of ganglionated plexi ablation? Then we would have excellent result with Affera.
Yes, I have another hypothesis about that. What do you think if PFA is so efficient that it's transmural per se, while thermal energies sometimes are not transmural, and when they reach the ganglia, so they have a ganglia effect, it's an indirect sign that they are transmural in this case. And this would explain why you have a differentiation between a vagal response and non-vagal response for thermal, but not for PFA, because for PFA, it doesn't touch the ganglia. You demonstrate very well, but in fact, the vagal reaction for thermal energy could be a sign that the lesion is more effective and then provides better results. It's just hypothesis.
I completely agree with you. That's another brilliant explanation of that. Absolutely.
Okay, would there be any other questions? No, then I'll leave the word to Carlo for the wrap up and closing remarks. Thank you very much for this last session. It was extremely interesting. Well done.